after talking about the doctors, now we move on to the reactions of the nurses during the time of Kubler-Ross. So again, it's the 1960s. Kubler-Ross, who's a very young consultant in the Department of Psychiatry, trying to interview dying patients, trying to understand them, so that by understanding them, we can take care of them better. We can be more compassionate. So, of course, you cannot show compassion without empathy, and you cannot empathize without understanding. So, and you cannot understand if you don't spend time talking to and talking with the patient. So that's what she proposed to do. Of course, our biggest problem is these patients are not her patients. And consider this is a big academic medical center. And of course, the ones in charge of the patient would be the big specialist. I mean, if you are terminally ill, that means you have far advanced disease, whatever it is. I mean, it could be heart problems, could be lung problems, could be kidney, all sorts of things. Most of the cases that gets labeled terminal would be the cancer patients, of course. Because some of the non-cancer cases would go in with, a sudden, they gradually deteriorate, and then they suddenly get worse and they die. The idea of trajectories of these non-cancer patients, and they're actually just as bad as cancer patients in terms of prognosis, we're not there yet. People are still working on it. So there's no such idea floating all over the place yet. I mean, they're just beginning to. So when we say terminal ill, it's mostly cancer, because cancer during the 1960s, I mean, they have lots of advances for all sorts of non-cancer things, but cancer is really difficult. Even now, adult cancer is very difficult to cure. 70 to 80 years later, we can only cure some of them. We're doing a slightly better job as far as children's cancer, pediatric cancer is concerned, but it's still bad, right? Anyway, so Kubler-Ross did her thing, and so she had to talk with the nurses to try to figure out who these patients are, and if their doctors are okay with it, who the doctors are, and how the patient is doing as far as the nurses is concerned. Of course, during that time, the nurses are there all the time. While they're performing their nursing duties, they have a sense, more understanding as far as the psycho-emotional and psychosocial issues of patients are concerned. Greater understanding about the psycho-emotional and psychosocial issues, family issues, and even community-related, culture-related issues as far as death and dying is concerned compared to the doctors. Even during that time, I would guess doctors have already begun trying to insulate their brains from those kinds of thoughts. It's 1960s. It's not old medicine. It's like already on the way to the kind of modern medicine that we know right now. And as far as what we are right now, doctors are here to cure, right? That's the same idea during the 1960s. You're not talking about turn of the 20th century, 1910, 1920. This is 1960. So what's the reaction of the nurses? She says very, very similar to the doctors. The reaction was very similar to doctors. And then the question is, what was the reaction of the doctors? As a review, well, it was aversion, it was hostility, and it was anger. I mean, so we talked about that already. And the nurses would have the same reaction. Why? Because they all work in the same institution. During the 1960s, if you're looking at these big medical centers, you're looking at an institution that has several personnel, several equipments, resources going in and out. So it's not like a doctor doing his own thing and the nurses going to the community doing their own nursing care and things like that. It's just one huge institution. And so everyone inside the institution would have some of the attitude and the values that's prevalent in the institution. And the thing about it is when we're dealing with these institutions, the people running the place would be the physicians, right? Most of the time. And so the values and the attitudes of the physicians encountered by Kubler-Ross when she was walking all over that part of the hospital, the nurses would have very similar attitudes and values, right? So again, it's hostility and sometimes anger. Now, but the nurses, there's a variation. There's a difference as far as anger is concerned. And there's a different kind of anger because, for a doctor, they're angry because of something else. And we talked about that. For the nurses, she actually tried to ask some of the nurses what gives. And of course, initially, the nurses won't talk. If a big shot specialist asks you, is there anything wrong? How come you're not Are you not satisfied? If you're a nurse, you either say no or you say something, but not too much, so that you don't make the doctor with his ego and bloated sense of self angry, and just make a really polite, very, very extremely polite suggestion, or give a very extremely polite, guarded opinion, and then just keep your mouth shut, right? Especially in places where hierarchy is more problematic. You have the big shot doctor trying to siphon out most of the financial gain out of the entire thing, and the poorly salaried nurses burdened with all sorts of duties and caring work. With that much power, you don't want to anger someone who can get you out of your job, right? In those places where the nurses are less empowered, I think the situation is slightly improving right now, but not too much, especially in developing countries or newly developed countries. And some of them were angry because of something else, and some were very vocal about it. They actually called Kubler-Ross a vulture. Don't touch my patient, you vulture. So vulture. That's a very strange word to use on a doctor. Right? They don't know anything about her. All they know is she's a doctor with a white coat, and that she's probably just like every other doctor they dealt with. Doctors taking care of this very sick patient with advanced illness, big shot specialist, and she's probably one of them. And for some reason, she wants to talk to this terminally ill patient, and they call her a vulture. What's a vulture? Why would you call someone, a doctor, a vulture? Well, a vulture is someone who's feeding on the carcass of a dead animal, the body of the dead. A vulture feeds on the body of the dying or the dead, right? And it's not helping the dead animal, right? So the dying animal, that's a vulture, right? So that's how they see the physician. They don't see Kubler-Ross because they don't know her. They see the staff physician who's attempting to talk to the patient about death and dying and all sorts of things as a vulture. And a vulture gets something out of that practice, and it has nothing to do with the person or the animal it's feeding on. So the motivation and the attitude and values are different. So what would be the motivating things? Well, a vulture tries to feed itself. It's for its own sake. It's self-interest, right? So what would be a self-interest as far as doctors is concerned? Well, the self-interest now is probably the self-interest during the 1960s, although in different varying degrees of importance. Money, financial. Of course, she's not going to get anything out of that unless she's planning to introduce a new service, and then she's going to get paid for the new service. But we know that's not what she's after. We know what she did later on, and it's not it. Maybe she's after fame. We also know fame is not it. Actually, when you start doing something like that, you're actually opening yourself to criticism. And instead of fame, you get the complete opposite of fame, right? You get criticized, people laugh at you behind your back. What the heck is this person doing? She's wasting her time, money, and effort doing something that's not important. Something that's weird and crazy. It's not even the job of a doctor. That's what you'll get, right? So it's not that. But they're thinking that. So, fame, money, possession, prestige. And she's another one of those vultures, right? Maybe doing a research work that would make them famous, but Now, once they get to realize that she's not it, she's not just like those other vultures. Of course, there's not a lot of vultures. Usually when the patient's obviously clearly dying or terminally ill, the doctors start avoiding the patient. So they don't go there to feed on the patient. They start avoiding the patient. Now, some of the doctors still do vulturing stuff. And then that's the other thing. They're angry at her. So why would they be angry at the doctor whom she represents? And they don't know her. Well, they actually enumerated a couple of things. First, they don't really talk to the patient. Now, the nurses would be the ones who notice this because they talk to the patient a lot. And even if they don't want to, they have to. That's their job. That's the reason why there are nurses in the 1960s. Because in the 1960s, 1940s, 1950s, 1960s, things have gotten worse that it doesn't seem like doctors have any time, are too busy. I mean, that's the official word. Even if they want to take care of their patients and they're caring and compassionate, they're too busy trying to think of the appropriate tests and the appropriate procedures and the cures and the drugs and the medications and the interventions to make the patient live longer or to make the patient well. So the nurses are there to help the doctor care for the patient. So that's that's how it is. So the nurses are there. They even if they don't want to, they have to go in there, ask the patient how they're doing, and they of course do the other basic stuff, monitor the patient regularly. They come in and out of the room, and if you come in and out of the room, things become personal. You don't just tell the family and the patient, don't talk to us about personal stuff. So they're more exposed to the personal experience of progressively worsening illness, death, and dying. So, and the reaction is they're angry at the doctor. Why? Because they feel that the doctor should be talking more to the patient. They should be communicating more to the patient, talking to and talking with the patient more. They should have already told the patient that there's nothing that they can offer that would cure them, and they're not doing it. So they have issues with the doctors avoiding disclosure. We still do that right now in some places, except that the doctors have found a way out of it. They refer to some counselor or a psychiatrist or the chaplain. In the old days, they actually refer to the chaplain. Now you have palliative care, clinical psychologists, counselors, and you have an excuse not to do it, right? Anyway, the nurses feel like if this person has been with you, and they've been hoping, you've been propping up their hope, you've been telling them that you have all these fancy drugs, science, technology, and tests and diagnostics, and you can make them better. That's the word out in the street, and that's your marketing gimmick. Actually, that's what you've been telling them. And they're very hopeful, since you're avoiding discussions about uncertainty and the fact that things seem to be getting worse, or the fact that you cannot offer anything anymore. So anyway, so the doctors should be doing that, and they're not doing it. So they're angry at the doctor. The patient and family would really need that kind of talk from the doctor. So they're angry. The excuse given by the doctors, as we talked about, and saying that, we're trying to protect the patient from being sad and depressed. Well, that might be the case for some. But again, the nurses are angry because they themselves can tell whether it's actually true or not, because they talk with the patients several times. And they know a lot of these patients can take it and will actually benefit from such a disclosure. They're troubled by the uncertainty of it all. They have no idea what's happening. And sometimes knowing what's going to happen, even if it's bad, feels better than not knowing, right? You don't know what's happening. And the doctor who knows what's happening is not telling you. So anyway, they're angry at the doctor. And the other thing that they actually said, which is very interesting, is they're angry because they're leaving them out of the rounds. When the doctors go in and talk to the patients, they leave the nurses out. And the nurses feel like, I talk to them every day. I actually understand them and actually can help out with the discussion. They'll probably do a better job if I was in the room. And for some reason, they're left out. One possible reason is the doctors don't feel like the nurses are going to contribute much if they're inside the room, which is really a very poor understanding of what nursing is all about. And actually, if you consider the idea of nursing as a profession, they should be inside the room with the doctor, or the doctor should be talking to them a lot before they enter the room. Now, for some reason, during the 1960s, that wasn't happening. Right now, I think for some places in the developed world where medicine has advanced far enough and realized its errors in the past, things are improving. Doctors talk to the nurses, and nurses actually are given more duties, more training and more duties to take care of the psychosocial part of care. Now, if you go to the developing countries or the newly developed countries, things are still bad, right? So the way doctors look at nurses, and what's this nurse going to contribute? And the nurse is just supposed to carry out your order. I mean, in some places where there's this terrible, really poorly structured hierarchy, where this well-paid, very doctors driving with their fancy cars and going to their fancy hotel restaurants and going to their fancy 5-star conferences, and this poorly paid nurses. I mean, if you consider the job that they're doing, that shouldn't be the structure, right? It shouldn't be them and them. It should actually be them and them, right? Some of the nurses in some countries, I'm not saying which one, I'm not saying which ones, just to keep this talk less threatening, I'm not going to say which ones, and I'm familiar with a lot of countries. So it's not like I'm talking about my country. The nurses are really poorly paid. I mean, the income is so low and the salary is so low. And, anyway, that's not the topic. And they also notice that, the doctors are not doing much. And when they talk to these patients, what they talk about is something that might cause more harm than good, and something that's not going to help, because they keep on ordering stuff that's not really going to help. And the nurses feel like they're using it as a substitute for talking about the more important stuff. Meaning they go in, what they should be doing is telling the patient the situation and what's really happening. And instead, they continue with this sense of false hope, and then they order all sorts of tests. Don't worry, I'll order this or that, and we'll do this. And in their mind, they've seen this a gazillion times, and they work in that ward, and they've seen the same story repeat itself several times. I mean, that test, that procedure, that intervention, that surgery, that medication is worthless for a patient in this kind of condition. They don't even have evidence that it will work for this kind of condition if it's this far advanced. And that's the only thing they do. They sit down, they talk to the patient, but they only talk about the thing they're ordering, and they're avoiding the more important things they really need to talk to the patient about. The fact that they're already terminal, the fact that they don't really have a lot to offer anymore. They avoid that topic, and they just come up with all these orders. And the problem with all these orders is they cost a lot of resources. As far as the patient is concerned, or the family is concerned, or as far as the community is concerned, if this is a public or government-run hospital, as far as the community resources are concerned, right? So instead of helping out, they're probably adding on to the financial burden of everyone, especially the family or the patient, if they're paying it out of pocket or part of it out of pocket. So they're angry at the doctors at that, okay? Now you can understand why they're very angry. I mean, why some of them are very angry. Because if the doctors don't talk to the patient, what happens to the patient who's really deteriorating? I mean, it's not like the patient don't know. Kubler-Ross and Cicely Saunders, the founder of the modern hospice movement, as early as the 1960s, are already saying patients will know whether or not you tell them. And it would make sense. Like, you're in this ward and your doctors are coming in and out, and you can look at their facial expression. I mean, doctors are not great actors. They can lie to you, but, some of them are good actors, but, even if they lie good about how effective or how hopeful things should be. But anyway, you were in this room, and doctors are ordering all sorts of things, and they're excited, and they're carrying out orders, and they're telling you all sorts of numbers, and suddenly they're ordering less, and obviously you're getting sicker. Usually when you're getting sicker, they should be doing more, right? Because whatever they're doing, it's not working. But it doesn't seem like it. The interventions and orders are becoming less and less. And suddenly, when you're really near the end or terminal, even the visits of the doctors are becoming less and less. Even the nurses visit you less and less. Of course, they cannot really avoid you altogether, because part of their job is to go in and out of the room doing at least the basic nursing care duties, right? Even if they visit you and often keep on telling you that things are hopeful, your body will tell you that you're deteriorating. And so you get to know even before the doctors tell you. There's actually several studies pointing to that, and the studies are saying that patients tend to know several weeks or several months before the actual disclosure. Anyway, so when the doctors don't tell them, so who gets to feel all the repercussions or all the effects of the doctors not confirming their fears, the ongoing emotions associated with fear, uncertainty, being kept out of the loop. You can imagine all sorts of emotions running all over that room as far as the patient and family is concerned. The patient's getting worse, and then the doctor's not telling them anything. Who gets a whiff of that? The nurse, who has no choice but to come in and out of the room and at least check on the patient, right? The burden of dealing with the emotions and the family issues would fall on the nurses, because the doctors are not doing anything. So that's one of the reasons why they're angry. Another reason would be probably they're angry because They want to do something, but they don't know what to do. I mean, at least some of them had told Kubler-Ross that, we want to care. I mean, we understand, we empathize, but we don't know what to do. We went through nursing school. There's not much about this. It's actually better in nursing school. There's more psycho-emotional, psychosocial stuff in nursing school as far as illness is concerned. There's more push towards compassion and caring compared to medical school in the 1960s, 70 to 80 years ago. And so what's happening now? Well, it's either the same and it's not the same. Things progress to somewhere. It's either improving or it's either worse. I think it's worse, right? The values and the attitudes of the 1960s, the thing that was a problem during that time, has gotten worse. And it's been here for so long that people actually think that's the way things should be, or there's no way of changing it. Anyway, that's not the topic. So part of their anger is the fact that it shows them every time a person dies, or every time they encounter all these emotions related to the fact that the doctor is not dealing with it. Some of them are probably angry at themselves for not doing a good job. So it's a projection of their difficulties. It's a projection of their anger, and they're projecting onto the doctors. Of course, I think they have the right to be angry at the doctor if those doctors are doing exactly that, because I think that's part of the doctor's job. Now, obviously, in the 1960s, a lot of doctors, especially in that part of the hospital, it's a big shot. You have a very severe illness, so it takes a brainy person like ourselves to figure things out with all our science and technology and things like that. So that's my job. Caring and talking and this compassion, understanding and empathy stuff is not part of being a doctor in the 1960s. I think that's what's been circulating during that time. The job of the physician is to figure things out, put a label on it, and then sample through all the possible things modern medicine has to offer, and then order it. The tests, the diagnosis, the treatment, the drugs, the procedure, and stuff. Now the question is, what if there's nothing left for you to offer? Well, the answer is, it's not your job anymore. So caring has been taken out of the equation. Since you don't need to care that much, you don't need to be personal that much, then what's the need for actual, real communication, disclosure, understanding, and empathy? You don't need that, right? All you need to understand is the objective things happening in the organs and the objective results of the blood test, and that's pretty much all you need to do, right? And that's already happening during the 1960s. Anyway, some nurses would have actually told Kubler-Ross, they wanted to do something, but they don't know how, and they don't know what to do. Lack of training. Now, of course, things are different right now. I mean, we have like end-of-life care workshops and palliative care or hospice care skills workshops for everyone. There was a push to put it in the training program. Now, whether the attitude and the culture and the value system has changed, that's another question. That's a different matter. We can teach everyone ethics and proper behavior and compassion and caring and things like that during the early years of their training. But, if you expose them to something else inside the hospital and outside, as far as the values and the attitudes of your supervisors and trainers are concerned, I mean, what's the point? How effective is that lecture? How effective is that discussion? Zero, right? So they still turn out just like everyone else. Nothing improves. Anyway, and most of the issues that she encounters is also similar to the issues of doctors. Like I said, 1960s, the nursing profession is actually going in the same direction as the medical profession as far as becoming more cure-oriented, objective. Because if you don't think like that, and you're like a nurse in a structure that's run by doctors, that's run by business concerns and everything else, you'll be out of the job in no time, right? So of course, the nurses also put up a good fight because they're still very much into psycho-emotional and psychosocial during the 1940s, 1950s, and the 1960s. At least some of them are, or at least their academic, scholarly field still was. Anyway, in this university, this big university medical center, according to Kubler-Ross, a certain ward or wards where most of the incurable or terminally ill or dying patients are kept. And even if she doesn't tell us, I mean, we can guess there's such a thing. It would make things more efficient. Like you have a ward where things are coming and going, patient gets wheeled out for tests and procedures and things like that. An active execution of the modern medicine, testing and interventions to cure the patient. And then you wheel the patients who are getting worse and worse and worse, and then you don't have anything else to do for them. You put them in another place. And this is the ward for that. This is the 1960s. There's not a lot of home and hospice care yet. Cicely Saunders, the founder of the modern hospice movement, was just starting out during the 1960s. And she didn't start with home care. She started with institutional hospice care, right? So home care was, is still something that will need to be developed later on, right? So the patients who are very sick with advanced something, most of these patients are advanced cancer. The non-cancer end-of-life care developed later. Why? Because of the trajectory is different. Cancer, you diagnose cancer, you know if you can cure it or not right off the bat or very early, and then the patient just left there to die for the next several weeks or for the next several months. So it's mostly advanced cancer cases. And she describes a lot of advanced cancer cases. Of course, adult cancer during the 1960s is very difficult to cure. People, even now, it's still hard to cure. I mean, we tell everyone we have so many advances, but if you really look at it, after 70 to 80 years, we really haven't changed the course yet as far as advanced adult in general. I mean, there are certain kinds of adult cancer that, we've been able to take care of. Actually, the trick is to pick it up early. Of course, there are problems with that, but we won't talk about problems with, that's not the topic right now. Anyway, there's this ward with a terminally ill patient, and the thing about this ward is it's very quiet. Doctors and nurses go in and out of that ward infrequently. You see less of the doctors, and you also see less of the nurses. Of course, the nurses don't have any choice. They still have to go in and do their basic nursing care as far as the patients are concerned. Doctors are an altogether different matter. You barely see the doctor, or you see them for a few minutes and then they're off to the next bed. Compared to the other ward where they have all sorts of things in their head that they can actually put on paper, like, this test, this medicine, this procedure, and they get to stay more because they enjoy being able to know what to do. Now, this one, they have no idea what to do. And like I said, they probably even think it's not their job to do care for the terminally ill or the dying, even if this person is suffering so much because of the progressively advancing disease that they promised to cure. And it's still the same disease. And they're still the same experts of that disease, except that they don't have anything left in their brain to make the disease go away. So what happens? They don't visit the patient anymore. Or they just, it's just really fast, hi, hello before the patient can say anything too emotional or personal. They don't even disclose. Anyway, and Kubler-Ross spent a lot of time in that ward, obviously. If she's going to interview someone, she would be going to those kinds of wards. And her interactions with the nurses working in those places, the reactions are varied, but there's this particular reaction that is fairly common. And the reaction is, it's absurd and it's a waste of time taking care of these patients. Some would even say it's wasting our time, effort, and resources taking care of this patient. It's absurd caring for this patient. They're dying. We cannot cure them. It doesn't matter what we do, they'll still die. So it's a waste of my time. It's a waste of the nurse's time. Of course, the big question is, why would a nurse say something like that? Not all of them. This, again, when I say something like that, it's not like all the nurses said that, but a decent number said that. And actually, the doctors probably would say, waste of my time and effort, except that he doesn't need to say that because he's not showing up. The nurses have to show up. So it's their time that's wasted. Now, one possible reason is probably just already a lack or a shortage of nursing manpower during that time. Maybe an actual shortage or medical industry, hospital industry induced shortage, which is what's happening in some places right now, 70 to 80 years later. If you look at the entire thing, it's one big commercial medical industrial complex, 70 to 80 years in the wrong direction. And that's what I think. Then one of the purposes is to gain more income and resources so you can expand more and you can come up with more and more nice things to offer and sell to the takers, the patients who are sick, or the people who are paying for it, right? So just like any business, you have to try to maximize the amount of money you put into the business. And what's one of the most expensive things as far as running the hospital is concerned? Well, the manpower, the salary you pay the nurses. Even though right now, in some places, nurses are really underpaid. They're underpaid, and they're being made to do more than what's humanly possible. One nurse takes care of like 30, 40, or maybe more patients. Now, if you're in this medical center during the 1960s, the best way to save up on money is, you put the nurses where you're doing on the curable or potentially curable people, where you're doing all your procedures and tests. And since these people are dying anyway, just, put one nurse to take care of like 30 or 50 people. And why is it that important, right? Anyway, so it might be just a product of being overworked. Taking care of this patient in this wards is an absurd waste of my time. Of course, it should be much more than that. It's hard to imagine someone saying something like that, especially if it's a nurse or a doctor. You look at this person who's very sick, who's suffering because of the disease, and then you have doctors and nurses with this kind of attitude. It's an absurd waste of my time and effort. There are probably other reasons, but it might be a coping difficulty being expressed in a statement like that, or it might be the same situation as in the doctors. If you remember, when we talked about the doctors, the ones with a value system or an attitude that's open to the ideas of Kubler-Ross, that's important to sit down, to communicate with the patients, try to understand them so you can empathize and so you can care for them compassionately. The ones who are more open to that kind of idea would be the least trained medical trainees, the first year, second year medical students, and then clerks. Now, as you go down the line, clerks, interns, residents, junior residents, senior residents, fellows, and then consultants. Once you reach the end, then it's an altogether different matter. Now you have the senior residents, or the more trained people, angry and hostile at Kubler-Ross because of all sorts of things. And one of the reasons is they don't feel like it's that important, or it's not the job of being a doctor. And you hear that all over the place right now. You attempt to do something like that right now, especially in the right kind of environment, a right kind of department or setting inside the hospital, or the right kind of hospital or country or community, then you'll get something like, you shouldn't be doing that. A supervisor or a senior talking to a young trainee who's misguided about this caring and compassionate stuff, telling this young trainee, you're here to be a doctor. You're not here to be a friend. You're not here to be family. That's not your job. Your job is to be a doctor. So don't do that. Don't waste your time and effort. It's just going to affect you emotionally. You don't need that emotional burden. That's not part of your job. I know you're young and you're altruistic, but I'm here to tell you, to train you so that you become a real doctor. And this compassion, empathy, and altruism kind of thing, that's not it. We still have it in our oath, and we still nod our heads when people talk about it, and they still feel like we actually do it. But don't do such nonsense. You hear that, you're not a saint, you're not a family member. Why should you stop doing that? You're wasting your time, you're wasting my time. I told you to order this, do this procedure, do this, and here you are wasting 20 minutes of your time just sitting there and trying to be nice to this person. That's not your job. You're a doctor. You're not a saint. You're not a nurse. You're not a social worker. You're not a priest. Stop doing that. And that's what you get out of training. Is by the time you become a consultant, you'll be just like this big shot idiot consultant who's talking to you, right? Anyway, that's not the top. Well, we won't go there. Some nurses, after a while, of course, I mean, if you're still a human being, after a while, nurses tend to be more open to Kubler-Ross, especially when they realize Kubler-Ross is a different kind of doctor. I mean, she's not like the other doctors. I mean, if you're a nurse and and a doctor is talking to you about whether you see something wrong with the way they do things, you either say no, just bow your head, and that's it. Unless you want to be out of the job, you don't want to anger this doctor, or with this big, humongous ego, or you make a really, really polite, significantly polite, well-worded, very humble kind of opinion and suggestion, and then if the doctor says something to defend himself or to brush it aside, you just bow your head and keep your mouth shut. If you're a nurse, I mean, during the 1960s, and I think it's still happening right now. Anyway, so when the nurses are more open to their laws, and after a while, when they hear themselves saying these things, and they know that there's something wrong with that, and it's not even human, and they want to share and they want help and try to sort things out, well, they just found the best person to help them sort things out. Kubler-Ross is a psychiatrist, and especially during the 1960s, psychiatrists still do a lot of counseling and psychology during the 1960s. There's not much compartmentalization yet, Of course, there's not a lot of drugs yet, so what do? You still have to do a lot of psychology and counseling. So they're talking to Kubler-Ross, they opened up to Kubler-Ross, and then Kubler-Ross says one of the issues they actually thrashed out is, and this is a very human reaction, you don't need to be a nurse or a doctor to feel something like this. It's really difficult to be exposed to such suffering, especially something that's related to severe illness, something that's related to death and dying for anyone. And since the doctors are gradually disappearing from the ward, it's the nurses who are seeing a lot of it, who are getting bombarded and getting exposed to the suffering, the emotions, seeing the patient and the family, even if they try to do their nursing care duties as fast as they can so that they can get away from that patient or the family. They still get to see it every day, several times a day even. Of all the people inside the hospital, they're the ones who are really seeing the suffering, the death, and the dying. And some nurses actually felt disgust. Initially, they're angry. Some of them said that they actually felt angry at the patient for dying while they're inside the room. The patient chose to die while they were inside the room, and now they had to see the entire thing and try to do whatever they can to take care of the patient and the family without the help of the doctor, who doesn't know what to do, or who thinks it's not his job to be inside the room in front of a dying patient whom he cannot cure anymore. So the nurse is saying, she should have died while I was out of the room. God knows what they'll experience, but at least I don't get to see it. It feels like the patient has just committed something terrible, committed an angry act at them. They feel like they don't deserve it. Why did you die in front of me? Showed all your emotions and suffering to me. I'm just doing my job. That's not my job. That's so difficult. You give me a burden. And if we really think about it, it's a very human, almost universal thing. Especially right now, it's a very death-denying culture or society, especially westernized or modern culture. And so the thing that we don't really want to think about is death, dying, and suffering related to something that's terminal. Why? Because it destroys all our narratives about life being pleasurable, fun, and full of promise and happiness. It destroys all that. And those things are the ones that's prevalent right now. We try our best to avoid that idea. Now, the doctors is also doing that in the hospital by not visiting the patient, or visiting the patient as fast as they can. The nurses cannot do that because they have to see the patient all the time. They're the nurse. Okay, so even pastoral care, the priests or the chaplains or the pastors experience that difficulty. It's difficult to watch someone suffer. I mean, it's difficult to watch suffering. It's difficult to watch death and dying, especially if you're trying to take care of that person. Actually, what's interesting is during the 1960s, in that particular institution, and I'm guessing in a lot of institutions during that time, issues about death and dying, about emotional problems related to disclosure, about difficulty in deciding on something that's very emotional, are referred to pastoral care, to the priest, the chaplain, the pastor, or the nun, because there's no profession that deals with that. There's no palliative care yet. Hospice care is just beginning. There's no psychologists or counselors moving around the hospital trained to do that. Actually, for several decades, people have avoided trying to figure that one out. So you punt everything to the pastoral care, the chaplain, or the priest, and the pastor, and the nuns. And so we move on to the next person. We discuss the reaction of the pastoral care providers, the priest, the chaplain, the pastors, the nuns.